All right, thank you very much for the invite, and I think I'm the last person talking on probably one of the most annoying topics, type 2 endoleaks. These are my disclosures, but none relevant to this talk. I have to thank my friend, colleague, and mentor, Dr. Neil Kane, for providing some of the slides to this talk. So type 2 endoleaks, they're really annoying. 10 to 20% of cases, you do a nice aneurysm, very happy, nothing on your post-operative angio, then the patient gets a CAT scan, and you see an endoleak with an enlarging sac. And, you know, they oftentimes are very complex in addition to being annoying, and they tend to be difficult to fix in addition to being annoying. And, you know, what the problem is that you have these multiple inflow and outflow, you know, egress vessels. And unlike open repair where you actually oversew these, we're not quite doing that with these endovascular repairs, and we're just hoping that, you know, the flow dynamics sort of cause these to sort of thrombose. The reality is that doesn't happen. So there are many approaches, translumbar, which I'll talk about most of my presentation. Transarterial, you can go from the SMA to the IMA, you can go through some of the common femoral collaterals to the pelvic vessels. Transcaval, which I have sort of kind of put on the back burner a little bit, and I focus more on translumbar, transarterial, but nothing wrong with that. And transgraft, I think people are getting pretty interested in. If the endoleak is right next to your graft, you can just puncture right into it and cover it with another graft. And you know, not to forget, open surgery is always a very, very good option. So, you know, the key for successful treatment of a type 2 endoleak with is really to get to the nidus. You know, when I think about these endoleaks, they start almost acting like an arteriovenous malformation where unless you get to the nidus, you actually will never get to it. So you can clip a branch, you can get to the branch, but it's really killing that nidus with whatever means you choose. And if there really is no nidus, gluing is not effective, or perhaps you have another type of endoleak, either a type 3 or a type 1. And once again, you know, when you do this, what you end up seeing is the glue or whatever you choose sort of going out into these vessels, which is what makes you feel good that you've actually done an adequate job. Some more images of these egress vessels tend to be very commonly either the lumbar or the IMA, but it's like sort of those, I call them the crotch lumbars, which sort of sit right at the crotch of, I see Dr. McKinsey give me the thumbs up on that. But, you know, right at the base of the aortic sac there, these two juicy lumbars that tend to cause most of the problems. And this successfully done. Just an illustration of transgraft and transcaval. Once again, I don't think there's anything wrong with it. My own personal bias is to put glue in this versus coils, because I feel glue just sort of kills it. And if you're going through a graft or through the cava, I'm always worried about the glue kind of getting dislodged at the wrong place. So that's sort of been my bias. So how do I do it? You basically mark out the patient, you mark out the intercostal space, and you want to go a hand's breadth from the transverse process. All of these are, you put them prone, left-sided puncture, between 12th rib and the intercostal space, and if that's the spine, you kind of feel a whole hand's breadth away from the transverse process, which is easy to do, and that's where you sort of is your entry point. But, you know, talking about all the technology that some of the previous speakers have mentioned, you really want to use the eye guide for this, and I'm going to get into it. So once you get a CAT scan, you pick the spot where you think that nidus is to really enter, and you want to kind of access that at a 45-degree angle. I know people do this blindly, which is very scary, and maybe I'm just a little timid, but I think just having the control and the feel of where you're going with the eye guide, I think really is helpful. And as you're advancing your needle, you'll feel a crunch. Don't be scared. It's just the wall of the AAA. And, you know, you take the needle out, and hopefully you should see blood. And the blood return, angioconfirmation, and that's when you sort of want to make sure you're working with D5 water, no saline, because sort of you don't want that glue to polymerize prematurely. And the key is, as you're pulling back your catheter, you want to do it slowly so as to also plug that crunchy aortic hole and not have really a problem. Just an illustration what the blood could look like, and it could really be it's pretty significant. I mean, the sac is like pretty pressurized. And once you get in, you start giving the glue, and you kind of want to really see it go out into these outflow vessels. Use glue with some oil, and the oil to glue ratio really controls that polymerization process. And we tend to choose 2.5 cc's of oil for 1 cc of glue. If you change that ratio, obviously the rate of polymerization will change. So I don't think it's a right or wrong answer as to what what you pick. Just pick what you're sort of comfortable with, and how slow or quickly you want to move with it. And just an example of a case. Once again, you get into the sac. The needle is, after the catheter is removed, is coming through, and you sort of do this nidusogram or sacogram and see a nice juicy outflow vessel, and you really want to see the glue going into these vessels and kind of killing that nidus. The iGuide, once again, is this technology. I think it comes with a lot of the Siemens as well as the machines, but we learned it through the Siemens, and this was when I was a fellow. You sort of pick that spot, so you're going to do that bony overlay to get the aorta lined up as you're doing this. Then you identify the nidus, and then you pick where you're going to enter on the skin to kind of get a feel. And then it's going to make a track for you, and you kind of want to review that track very carefully to make sure you're not going to any bowel or any organs that might cause you to cry later. But you just want to be cognizant of that. And then it really comes down to like really having a lot of good hand-eye coordination as to how, when you're advancing your needle, get different projections, like, different orientations of LAO and RAO to, kind of get a feel as to how your needle is going to enter and where it's going to enter. And you can see in this particular case, my geometry is a little bit off. So you really are relying on that iGuide and a recent CAT scan. Don't pick a CAT scan that's like 6 months ago to then go ahead and plan an endoleak. Probably a bad idea. And once again, once you get in, coil it. So we looked at our own experience a couple years ago, and this was published in JVS, I think, in 2020. We looked at 30 patients with type 2 endoleaks who went translumbar embolization, mean of 74 years, large enough for New York City, growth of 0.8 from prior scan, and we had a follow-up of about 19 months. And what we noted is that in 50% of these patients, you had complete resolution, stack stabilization, and sac regression. Another 37% required, they still had an endoleak, but the sac did not grow any further. And a small percent, about 10 to 15%, required additional embolization procedures. And one, in fact, ended up requiring open ligation of the lumbars. So we didn't experience any embolic complications, and we found that use of antiplatelet agents and large aneurysm sizes tend to be associated with persistent endoleak after translumbar. And interestingly, use of anticoagulation did not predict persistent endoleak. So, we concluded that it's safe, easy to learn. The iGuide, I think, is really an invaluable tool, and you really must have a nidus to be effective. And I think it's critical that these patients be followed, as every one undergoing an EVAR should be followed. My own lessons learned, I think it's really critical that, when a patient comes back with an endoleak, you not only look at the initial angiogram or the initial CAT scan, the post-op angiogram, but look at all the successive CAT scans to kind of get a sense, like maybe there's a lumbar that's open in a particular place that might be the problem, or the IMA is the problem. I myself find that large aneurysm sacs where, you tend to have a lot more thrombus, the contrast can sort of dissipate, and they tend to be more challenging to deal with and be a little more tricky. And, get the CAT scan not just with the arterial phase, but, the delayed phases to really see how this endoleak really blossoms up, because it's always interesting when you look at the arterial phase and it's a tiny speck, and then you look at the venous phase and the whole sac lights up, which is, never fun. And, when you're treating and following these patients, I think it's critical to be patient. With that, thank you very much, and happy to answer any questions.